Hello, everyone. We're going to talk today about Cushing syndrome treatment research, highlights from ENDO 2024. I'm Maria Fleseriu, professor of Medicine and Neurological Surgery and director of the Pituitary Center at Oregon Health and Science University in Portland, Oregon, and it's my pleasure to be with you for this CME. These are my disclosures with funding to the university and scientific consultancy. The learning objectives of this talk are to describe the latest research being presented to better manage individuals with Cushing syndrome and its clinical relevance, and to share new information with their clinical team. Cushing syndrome and Cushing's disease. What are they? A rare endocrine disorder characterized by chronic hypercortisolism. It's Cushing syndrome. So everything from endogenous and exogenous. The incidence of Cushing syndrome endogenous, it's 2 to 8 per million, but keep in mind that this is probably underdiagnosed. The most frequent type of Cushing syndrome after the exogenous Cushing's is actually Cushing's disease. So this is a pituitary adenoma producing excessive ACTH, leading to hypercortisolism. And the symptoms described on the right, and I'm going to point out a very important one, range from mild to very severe. So each patient is different. And when we're talking about symptoms, as you can see, we have clinical features that are more consistent with high cortisol, and then also comorbidities. And some are more specific than others. So for example, when we're talking about abnormal weight gain is more in the abdominal area and higher percentage in a short period of time with depression, anxiety, headache, of course, the round face, the muscle weakness is very specific. Women have acne, but also sometimes men. The stretch marks are large and red. Again, not positive in all patients, but if the patients have them, this is a higher likelihood of the patient having Cushing's. And then bone complications, many patients every year, they present with long-standing Cushing's, and some of them, younger women, had a fracture a few years ago, and they didn't have a workup to see why they had that fracture. So this is in general about Cushing's. When we're talking about treatment algorithm, I'm going to focus first on the Cushing's disease, and then we'll review some other type of treatments too. So if you look here, when we're talking about Cushing's disease, first, pituitary surgery. Remember, it's a tumor in the pituitary. Pituitary surgery is the first line. However, some patients will need preoperative medical therapy first, and then in some patients, pituitary surgery is not feasible. So if they have persistent disease, and you see here in large, then it's getting more complicated, because if the histology is negative, I always go back and try and figure out if the diagnosis was correct. If the histology is positive, then I move usually to medical therapy. Rarely, if it's the first surgery was not done in a specialized center, we recommend reoperation, or if the tumor is growing. And then depends on how the patient is doing between medical therapy, radiation, sometimes both, and sometimes all of them, reoperation, medical therapy, and radiation. What is the most important, and I want you to see at the bottom in orange, is once we start a medication, we have to decide if the medication is working. Is the patient controlled, partial control, or no control, and then we just have to switch to something else? And if it's partial control, then we will need probably combination therapy, or sometimes even switching to another medication also. Which medical therapy we have available? For Cushing's disease, we have 3 groups: neuromodulators of ACTH release, including pasireotide, approved by FDA, and cabergoline used off-label. And then the other 2 groups are also used for all types of Cushing syndrome. Adrenal steroidogenesis inhibitors, and you have them here in alphabetical order. However, I wanted to point out that FDA approved are just levoketoconazole and osilodostrate for Cushing syndrome, and mitotain is approved for adrenal cancer. And glucocorticoid receptor blockers is approved by FDA for all patients with Cushing syndrome and hyperglycemia. So ENDO 2024 was in Boston a little bit earlier this year, and there were many, many clinical trials discussed, real-world study, some studies on quality of life, on comorbidities, and many more. Of course, I don't have time to review for you everything, so just go to the abstract and see how interesting was the world of Cushing's and pituitary in general at this end of 2024. But I will share with you some important studies, and I would like to start with a very interesting study, real-world impact of Cushing syndrome, a study done by patients. And unfortunately, the conclusion is that while outcomes have improved over time, patients with Cushing syndrome continue to report diagnosis delay, confusion about treatments, and feeling ignored once the cortisol is normalized. There were 150 questions, and as you can see, many, many responses from an international array of country. If we're looking at the results in detail, you can see that from patients' point of view, we are not doing a great job. The patients are still trying, 75% still trying to determine the new normal. The memory problem that they didn't have before, 80%. They couldn't go back to work in more than 6 weeks. This is usually expected, and we talked about that, marriage problems. And what I was most bothered by was that half thought that the feeling that the medical team was unable to support them beyond cortisol issues. And again, I think this is very important for us as physicians to think about how we can support the patients, sometimes sending them to other specialties, of course. And the results demonstrate the ongoing burden of hypercortisolism, as I showed you earlier, often starting 7 years before an official diagnosis. So overall, it's anywhere between 4, 5, 7, but it's true, patients could be selected, and that's why they answered the surveys, because they didn't do well. However, these are very important results. So let's switch from quality of life and how the patients are perceiving that we're not doing a great job besides cortisol in new studies, prospective, retrospective, and non-interventional studies with FDA-approved therapies that have been reviewed and discussed in detail at ENDO. First, pasireotide, as you know, it's a multi-ligand somatostatin receptor ligand available either subcutaneous as BID or intramuscular once a month in different doses, approved to treat Cushing's disease in adults for whom surgery was not working or they cannot have surgery due to contraindication. This was a retrospective 3-year study, international, run from Europe. And as you can see, the design was a little bit more complicated, but you can see highlighted in red the most important things. Some of the patients, when they got into the study, this was retrospective, they were patients that were new pasireotide users. And as you can see, the control rate was pretty low overall. However, if they were prior pasireotide users in the past, so that means they responded or partially responded, the control was 67% overall. And then at month 36, the numbers were decreasing for previous users and with some dropping overall and less patients. But for new users, the percentages increased. How about Cushing's quality of score? Of course, we know that the blood pressure and the weight changed slightly, and we have to make, as you've seen from patients' reports, we have to make a concerted effort to look at comorbidities and other factors, not just cortisol. So if we're looking here, the Cushing's quality of life, we can see that it improved on treatment over several years. How about levoketoconazole? This is a cortisol synthesis inhibitor approved by FDA for treatment of endogenous hypercortisolemia. It's administered twice a day orally, and the approval was based on SONIX, that was a phase 3 open-label single-arm study, and LOGIX, a double-blind placebo-controlled randomized withdrawal study, also phase 3. So all these studies have been published. However, at ENDO, an additional post-hoc analysis from SONIX looked at something that's very important for all of us in clinic. Can we determine in advance which patients will respond and which will not respond? So the answer is somewhere in between, but it's important data. There were 94 adults with confirmed Cushing's, and the dose in Sonics, it's exactly how we do in real life. Starting dose is low, 150 twice a day, and then go up on the doses as tolerated and also based on how the patient is doing. And this particular post hoc analysis looked at, is the control depending on how high the UFC was at the beginning. And you can see there were, you can see in red that patients that had less than 2.5 upper limit of normal had much better response than the one that had more than 5 upper limit of normal. Also, what was important was that the liver-related adverse events were lower in patients that required that ended up being controlled. So we don't really know if this was due to the fact that because the cortisol was controlled and they had less liver-related AEs versus just the doses that were used were lower. As you can see, they were different. No statistical significance was done specifically for that. So we can say that where you start is very important for the likelihood of achieving normalization and also for the rates of AEs. And this has not been shown before. So briefly, so you can see a little bit better the numbers. Definitely the patients that for response rate were better responded if they were less than 2.5 or 2.5 to 3 versus more than 5 upper limit of normals. And the doses, if you look that's also important, that some patients needed higher doses to be controlled. Look at the maintenance doses in red, clearly the high UFC, higher doses, but also all of the doses from maintenance had to be increased in order to achieve control. Also at ENDO was a case series with 3 cases. And keep in mind, this is relative new medications and there are no other studies besides the Logics and Sonics. So this was new, was a report from MGH group. And I will go briefly through some of the cases. One was a 44-year-old male who previously took ketoconazole but stopped after surgery. And several years later, the Cushing's disease recurred with very high urine, and the patient refused surgery, underwent radiation and started levoketoconazole. You know that once you have radiation, you need medications for many years, most of the time. And patient achieved on a relatively low dose, normal UFC, but had mild nausea, and with reduced dose, doing well. Second case, pretty similar, just patient had 2 surgeries this time and radiation and had a 3rd recurrence. We see this all the time. The patient was treated with pasireotide, discontinued due to abnormal liver test, switched to keto, but the saliva cortisol remained elevated, so then was switched again to levoketoconazole, low dose, and then for this patient with levoketoconazole, late night salivary cortisol normalized, Cushing's symptoms improved, brain fog, mood disturbances. And then a 3rd case, this was a woman with presumed cyclic Cushing's disease. We all know that this is the most complex disorder to both diagnose and treat. This patient had transphenyloidal surgery with negative pathology, intolerant and uncontrolled with all other medications before and tried 4. Started levoketoconazole at lower dose, achieved normal saliva cortisol and UFC after 1 month, so success. However, drug later was discontinued due to development of a rash that was also observed with ketoconazole. So you can see a range of case studies with what to look at, how the UFC is normalized, how the saliva cortisol is normalized, and also AEs in the same time. Other drug studied in extenso at ENDO was osirodostat, and several new studies in addition to LINK-3 and LINK-4, which were the initial large studies that the drug was approved. It's a cortisol synthesis inhibitor, mostly 11-beta hydroxylase inhibitor, also an aldosterone synthetase. It's approved, same approval as the other drug, treatment of adults with Cushing's disease who cannot have surgery or had surgery and they have persistent disease. And it's oral medication also twice a day. So the LINK-3 and LINK-4, this was a large study that we combined as a pooled analysis all the patients that have been on treatment, so excluded, of course, placebo. And I want to remind you that this was a little bit more complicated, and you'll see in the abstract and hopefully in the paper soon, that the exploratory analysis looked at combination of all these patients, which increases significantly in a number, but then comes with some challenges. Particularly this presentation poster looked at the blood pressure control and the diabetes control. And you can see, and I will show you a little bit more details, that the patients taking antihypertension agents at the start of the study was 54%, decrease at week 72. And then the blood pressure improved, and I will show you soon. The same thing for diabetes control. Patients taking medications, the numbers decreased over time. So keep in mind that doesn't mean we don't have to look at the comorbidities in details, because in some patients with control of cortisol, you can decrease some of these meds, but not everybody's responding. So some patients will need even higher doses despite the control. So we have to look in significant detail. What's important here is the trend overall. As you can see, in blue are patients that didn't take antihypertensive medications. In red, the one that took it. And you can see over time, of course, the numbers are changing. And of course, at 72 weeks are less patients. But you see the trend that it's decreasing with starting treatment and then persists in relatively normal range, as you can see. Though we know now that the normal ranges are changing with the new guidelines. The same thing for diabetes. The curves are the same. Patients that are taking medications, patients that are not taking medications. I'm showing you the A1C, but the glucose was also the same. You see improvement and then stay stable over time. The other very interesting, so these LINX-3 and LINX-4, as you know, were large prospective international trials. Now the LINX-6 that at ENDO, the one-year interim report was presented, is real-life study. So patients are treated with osilodostat, and then they are followed over time. But real-world scenario, different indication for disease. And as you can see, this was, again, more focused on Cushing disease than Cushing syndrome, were mostly female, and again, makes sense because this is related to Cushing's disease. And the median osilodostat exposure was 5.5 months because the interim was at 1 year, but then again, some patients got in late. So if you can look at the 3 months efficacy data, and I have it on the right and it's highlighted in red, was 71.4, pretty similar to the studies overall. In the late night salivary cortisol, 50%. I wanted to point out that the median osilodostat dose was 5 milligram, which is lower than in the studies, with a minimum of 1 milligram per day. The approved lower dose is 2 milligram, though I have many patients on 1, and the maximum 60 milligram, and the 60 milligram clearly were some ectopic patients. That's one of the issues when the initial diagnosis is so different from Cushing's disease to adrenal to ectopic. The doses don't mean so much, and the range is very important. 4 patients discontinued treatment due AEs, and 12 patients reported 44 AEs thought to be treatment-related. Most common were vomiting and dizziness. So if we're looking, again, separated new users from prior user, because once you have an observational study, some of these patients were treated before. So if we're looking at the prior users in blue and new users in red, you can see that the normalization of UFC cortisol was higher in new user, the same thing with late night salivary cortisol and the serum cortisol. Now, how about AEs? I think from clinical point of view, this graph from the poster is one of the most important one. And of course, you can look in details at all the numbers, but what I wanted to highlight is that you can have, as you can see, adverse events, both in new user and also in prior users, way more at the beginning when you start. So new users, as you can see, 4 patients reported 7 SAEs. So it's important to look at all patients all the time that are on any drugs, but especially with a potent drug with risk of adrenal insufficiency that's higher than with others, as is for osilodostat, we need to follow very closely the patients. And though it's clearly decreasing over time, we can see with some intercurrent illnesses, we can see it later. So it's important. I always tell the patients, yes, it's especially at the beginning, could be withdrawal and then adrenal insufficiency. The likelihood of adverse events, of most adverse events, is decreasing over time. However, you can still have later, and I always give them steroids to have at home to take if needed, and also injectable, and then call us. How about REAL-7? This was a retrospective, non-interventional study evaluating the safety and effectiveness of osilotastat. And this one, I told you the other one, it's so complicated because it has all the etiologies. This one had excluded Cushing's disease. So it's just any type of Cushing syndrome, non-pituitary, also in a real-world setting. And because the Cushing's disease was taken out, as you can expect, the largest proportion of patients needing medical therapy was the ectopic Cushing's. That was more than half, which increases the severity of the disease. So you already can see that because the median osilotastat exposure and dose was 164 days. And again, though it was 5 milligrams, you can see between 1 and 60, and many patients were on maximum dose. 60 per day is the maximum approved dose. If we're looking at the results in efficacy for UFC, this was 44 at week 12 and 50% at week 24. And again, if you start very, very high at week 12, sometimes it takes time, unless you start with block and replace and very high dose, it takes time to normalize. Again, the more you start higher doses to control, the more adrenal insufficiency, and as you can see here, and sometimes even hypokalemia you can see. 28% died during the study. We expect this in patients with ectopic, and which is caused mostly by cancers and adrenal cancers, 10% because of neoplasm progression, and 14% discontinued because of planned surgery for Cushing syndrome. Either a tumor appeared or the surgery could be done. So this was the largest study that looked at osilotastat outside the Cushing's disease arena for all cases, and it gives us more perspective in how to use the drug. Now let's look at other studies. These were retrospective with off-label therapies for Cushing syndrome. The study from NIH looked at ketoconazole. It's a cortisol synthesis inhibitor. It's approved in Europe to treat Cushing syndrome, but not approved by FDA. And there were 35 patients where the ketoconazole has been used with evaluation for efficacy. And as you can see, it's not UFC. This time, for this particular study, the serum cortisol normalization was considered as controlled, and 17 out of 35 patients were control. What was important, and usually we don't do that, as you can, the median days between doses was 2 versus 4 for uncontrolled. So the increased doses was much faster than in other studies. And you can see that if they were on stable dose for 3 days after the increase, how the mean cortisol is decreasing. So this is important because that shows that efficacy and hepatotoxicity are linked, but also you can really go up on the doses as needed. And yes, the LFTs rose to more than 30% in many, many patients, 27 out of 34. But the study says not everybody should stop the treatment. I have to say, usually if it gets more than 30%, I stop the treatment, sometimes even as less than twice upper limit of normal. But based on this study, maybe we will change. But I think the most important thing that you see in red is we can increase the dose much faster than we do for some patients, though I would be worried about adrenal insufficiency in some of them. How about etomidate? This is a cortisol synthesis inhibitor. It's the only intravenous one that we have available. We use for patients in ICU. This time was a case study of a woman with metastatic adrenocortical carcinoma, poor surgical candidate, requiring intubation. So again, none of the oral medication will work. And after 8 days, cortisol decreased from huge numbers to the goal on low-dose etomidate infusion. Another study showed, but not in intubated patients, that you can use it also on the floors, though in US, this requires ICU. How about prospective studies with investigational drugs? We're so lucky, and this year at ENDO, we had several studies presented. With relacorilant, a selective glucocorticoid receptor modulator. It's highly selective with no activity at progesterone, mineralocorticoid, or androgen receptors. And it was the phase 3 double-blind randomized withdrawal study from GRACE. So our patients with Cushing syndrome and hypertension, hyperglycemia, or both. Keep in mind that relacorilant, because it's blocking the cortisol, the glucocorticoid receptor, the cortisol as a value. So we can check urinary free cortisol as you've seen in most of the other studies. So the endpoint has to be a clinical, the same thing as we did for mifepristone. So for primary endpoint was considered loss of the hypertension control in patients that were on placebo, and of course safety, and for secondary hyperglycemia control, as well as other cortisol-related comorbidities. So if you're looking here on the left, higher is hypertension. All patients with hypertension had decrease in systolic and diastolic. Hyperglycemia, also on the left, you see some decrease in area under the curve for glucose. And on the right, higher up, you see blood pressure, hypertension responders who ended up randomizing. And then also hyperglycemia. Overall, you can see the mean A1C decreasing from 7.2 with 0.3%. In the diabetes range from 7.6 decreased to 0.5, and the full-blown diabetes went from 8.1 with a decrease of 0.7. So depending how high the patient was, saw more benefits with this drug for hyperglycemia. Significantly more patients who switched to placebo lost hypertension. Keep in mind that this was the primary endpoint for this study. And furthermore, patients receiving relacorilant were 5.9 more times more likely to maintain the hypertension response achieved during the open label phase, because that's what randomized withdrawal means. Patients are on drug and then they switch on either placebo or the drug. And then after that, they will go in extension in most of the studies. And what was interesting was that no clinically meaningful differences in adverse events were observed between the relacorilant and placebo arms. It's always nice from this point of view to compare the studies. Another drug, atumelnant, it's a once daily oral, non-peptide first-in-class competitive and selective melanocortin type 2 receptor antagonist that blocks ACTH-mediated G protein activation and subsequent signaling. So this is a very interesting and novel concept. As you can see, was a phase 1b/2a open label study presented. Very small, but very important data. 5 patients with ACTH-dependent Cushing's, the study was done at NIH, received the drug, 80 milligram every morning, 10 days, followed by a 4-day washout. By day 2, so this is how the drug works, all participants experienced signs of adrenal insufficiency. The early morning cortisol was already low and started steroids. Many features of Cushing syndrome improved. So even in short time, blocking the ACTH mediated G protein activation is important. And of course, we need much larger study, but for a signal, this was a very important data. Another drug that was presented was some data on HSD1 inhibitor, clofutridine, which is a novel mechanism of action to target the source of cortisol. It's an oral once-a-day administration, and complex monitoring might not be necessary based on the mechanism of action. Clofutridine has demonstrated the ability to lower intracellular cortisol levels in vital organs with a favorable safety and tolerability profile in 5 clinical trials. I wanted to mention that all of them were outside the Cushing syndrome arena, which showed improvement in glucose, A1C, cholesterol, and triglycerides. But there are ongoing studies in Cushing's disease and adrenal Cushing's that we are awaiting to see if another drug with a totally different mechanism can potentially improve clinical signs and symptoms. So in summary, I think this was a very important meeting for pituitary disorders, as I mentioned earlier, but particularly for Cushing's. An international quality of life survey demonstrated the ongoing burden of Cushing's, often starting more than 7 years before an official diagnosis is made and continuing indefinitely. Pasireotide showed increasing full response rates over time in new users, stable rates in prior users, and improvement in clinical signs of Cushing's at 36 months. Also, another trial ad hoc analysis showed that a lower UFC at baseline predicted the likelihood of achieving normal UFC following 6 months of levoketoconazole therapy. And also, even more important, the lower UFC at baseline was associated with lower dose requirements and lower rates of potentially clinically important liver AEs. And that's very important from clinical point of view. There were several studies on osilodrostat showing that it's generally well-tolerated and provides early and sustained cortisol control in patients with both Cushing's disease and other causes of Cushing syndrome, with improvements maintained or enhanced during long-term therapy. And this is aligning with previous clinical trial data that we have published. Cortisol normalization, even more important, is associated with improvement in hypercortisolism-associated comorbidities in patients with Cushing syndrome. And very important, the doses in real-world setting vary by etiology and severity of the disease. So if I see a patient, I never tell them how high they would need to go on the doses. I usually say we're up titrating very slowly. And as you can see, the median dose was 5 milligrams per day overall, but some patients require much higher doses. And hypocortisolism-related events are the main AE, especially at the start of treatment, but I've shown you also later. So patients have to be aware for all Cushing's drugs, but especially for the most potent ones. A retrospective review suggests raising ketoconazole doses very fast, Q72 hours is possible. I have never done it like this. Usually I wait at least a week unless the patient is in the hospital, but this was done at NIH. Liver toxicity risk correlates with baseline AST levels. And also important from this study that while most patients experience a rise with more than 30%, the treatment should not be stopped unless the LFTs exceed 3 times upper limit of normal. Etomidate is effective in controlling cortisol levels in patients requiring intubations, and we saw a case study. Relacorilant is a selective glucocorticoid receptor modulator that appears to be safe and effective in phase 3 studies. And atumelnant, an oral MC2R antagonist, shows promise in early clinical studies. And with that, I hope I showed you that these are very exciting time for the community of patients, caregiver, and physicians dedicated to Cushing syndrome. And I wanted to thank you to all of you for listening to us. Thank you.